All right. So we're talking about. So we talked about the severe, the severe alcohol withdrawal. We talked about the Valium. We talked about the phenobarb. Phenobarb. The typical protocol is high, moderate, and low, and you get 15 milligram per kilogram. Take that dose. Let's say it comes to 1,000 milligram. You divide it 40%, 30%, and 30% in the first day. Every 8 hours for the first day. These are tiny doses here, like 400 milligrams, 300 milligrams, 300 milligrams. Nobody's going to go to sleep with it, But this was a study. You have to understand, this is a study. They were trying, safety was a little bit higher than everything else. They weren't sure what's going to happen, all of these things. So we looked at the dose, looked up the dose for phenobarb for seizure. So when you want to load somebody with phenobarb because he is having seizure, what would you give this patient? 10 to 15 milligram IV bolus per kilogram, IV per kilogram bolus. So why are we doing all of this shit here? This patient is more agitated. It's actually need more than a seizure patient. So we basically canceled all of this. And we have a very simple protocol, 10. That's the protocol. 10 milligram per kilogram IV times 1. And then you have a rescue dose, maybe 5 milligram during that 24 hours per kilogram. You can give that. And then, of course, after that, you can switch him to PO, 100 milligram. The elixir is better because the numbers you can remember. The elixir, you can choose the number. The tablet is 92.3 milligram. Who's going to remember that number? Anyways, 100 milligram, 50, 25, and 12 and a half, and you send them home. If the patient wants to go home here, let him go home. It's a long-acting medication. That's going to be okay. There's another lie that they made it was not a lie, it's a beautiful lie. I mean, you want to kiss that, whoever researchers that made this research protocol, because they made their study work. It's very difficult to control the interns who spread over everywhere in Mass General and BI to control how much Ativan they're gonna give. Every time you're gonna get called about an agitated alcoholic, you're gonna give Ativan. You don't care if he's on a study or not a study. So they made a lie, and the lie is if you give benzos with phenobarb, you have a higher risk, exaggerated risk of respiratory depression. You don't. You don't. It's just additive. As if you give more phenobarb, right? There's no synergy here. It's just like as if you're adding more phenobarb. That's all. So it worked because nobody gave Valium, and we still have a residual of the culture until now. But now it's liberalized. You can give, you can really give more Ativan if you want with the phenobarb. By the way, when I say that, like I had a resident once, give as much Valium as he can tolerate personally, and you couldn't put the patient to sleep. But the advice that I give you for both, and I don't want to be cavalier about it, these two have very wide therapeutic margin, Valium and phenobarb, only if you're not combining it with narcotics. If you combine it with fentanyl or anything else, narcotics, then it's synergy now. So it can actually put the patient to sleep, to apnea. And then mild DTs, that will be whatever what the floor wants to use, and then prophylaxis, you use beer. Any type of alcohol is prophylaxis. There's no need to have somebody, struggle through DTs when he's coming in here for podiatry case. Just look at or coming in for hernia case. Why would you torture the guy? Give him his alcohol. And then, I understand it's unethical and blah, blah. Hook him up with social work at the end and say, okay, go to AAA after. It's not a good time to withdraw or detox the patient from alcohol during, his COPD exacerbation, for example. And that is it.